Hi, everyone. Welcome to the Network for Public Health Law webinar, Protecting and Improving Local Public Health Authority to Advance Our Collective Health. Thank you for joining us today. My name is Leah Terry. I am a program coordinator here at the network. I want to let you know that the presenter slides, as well as a recording of this webinar, will be available on the network's website within about a week. You will receive an email when they're up on our website, as well as a post-webinar survey link, which we would really appreciate if you could fill out for us as well. Please feel free to use the Q&A functions throughout the webinar if you have any questions, and our moderator, Darlene, will try to get to as many as possible. So with that, I will pass it off to Darlene Huang-Briggs, Deputy Director of Special Projects at the network. Thank you.
Thank you, Leah. Leah, can you give me a thumbs up if you can hear me? She went off camera, so let's assume, yeah.
We can hear you.
All right, awesome. Okay, welcome everybody. Good afternoon, evening, morning, whatever the case may be for where you're joining us from today. As Leah said, I'm the Deputy Director for Special Projects here at the Network for Public Health Law, and I'm really excited for today's discussion with our panelist, which is bringing together years of progress in improving the local public health system, which is also where I got my start in this field. Local public health really is where the rubber meets the road, and I'm really glad to be showcasing that today with all of you. Okay, so next slide, Leah. Here's where we're going today. I will start with some context and level setting, which includes a whirlwind tour through some of the work of the Act for Public Health Partnership. You'll then hear from Jeff Mongaloo from the National Association of County and City Health Officials about their new Public Health Authority policy statement. We've then got 3 stories for you from Oregon, North Carolina, and the commercial tobacco control space that span a range of use of legal and policy tools along each of their journeys toward local public health system improvement. From Oregon, we have Sarah Lochner with the Coalition of Local Health Officials, Patrick Brown from the North Carolina Public Health Collaboration, and finally, Joelle Lester from the Public Health Law Center. You'll get to hear more from each of them about themselves and their organizations in just a bit. And then we'd love, of course, to then answer as many of your questions as we can. Next slide. So, what do I mean when I say public health authority? I use it as a shorthand way of describing the legal ability of a government entity, usually a state or local government actor like a public health official or a board of health, to protect and promote the public's health and health equity. You can see some other explanation here from the Act for Public Health website's FAQs. And I think what I want to emphasize here is that it's not necessarily limited to just legal powers of health departments. That is certainly a very important piece of public health authority, but there are also other actors, both governmental and non-governmental, that play important roles in the governance, functioning or not, and impact of the public health system. And that will be a part of today's conversation as well. Next slide, please, Leah. So here's another helpful description from the Public Health Law Center of state and local public health authority more specifically. It's focused on the most common actors we all think of, public health agencies and local boards of health. And of course, if you have specific questions about your particular situation in your city or county or state, it varies pretty widely from state to state. I hope you'll feel free to reach out to any of us on this next slide, please, Leah. So there are 5 public health law organizations that make up the Act for Public Health Partnership. And with funding from the Robert Wood Johnson Foundation and others, we've been working together to track legislation and litigation impacting public health authorities since the onset of the COVID-19 pandemic. We've been trying to keep the public health community informed of these changes, both negative and positive, and some, quite frankly, just not yet clear. Through resources, presentations like these, and of course, through direct consultation and legal technical assistance. from a variety of parties like all of you that are interested in preserving and improving the public health ecosystem. Next slide, please. If you're familiar with Act Public Health and the Public Health Authority work of others already, these next few slides will look familiar to you. But for those of you who are not familiar, these are a couple of the early reports that NACCHO and the network released describing a very clear coordinated attack by the American Legislative Exchange Council, or ALEC, and its allies to outright prohibit or shift or limit fundamental public health powers, especially emergency powers, and more generally to upset the balance of those powers for the collective good with individual liberties. These efforts happened across the country and were successful in rolling back public health powers in over half of states. Next slide, please. So think bans on employer vaccination requirements or mask mandates, as well as blocking the use of business closures or quarantine, and shifting power from the executive branch to the legislature for decisions that require public health expertise. This graphic is from our friends at Temple University's Center for Public Health Law Research, and it gives you a sense for the more than 1,500 bills that were introduced in 2021 and 2022 in state legislatures. Most bills were limiting of public health authority and focused on vaccines. You can see that there in the emergency measures regulation category. But some also attempted to expand public health authority. Next slide, please. Last year, Act for Public Health narrowed our legislative tracking focus to a subset of vaccine bills, since there was so much action in that space, and it really has sort of served as a bellwether for tracking changes to public health authority more generally. And what you're seeing here is that data set. Again, our friends at Temple have systematically coded and visually mapped school vaccine and provider scope of practice bills that were identified by the Association for State and Territorial Health Officials from January to May of last year. They're working on an update of this data set as well as many others. And so stay tuned for those updates on their websites. They also have a beautiful new website that does some great comparison features. Next slide, please. Turning to the courts, our friends at Northeastern University's Public Health Law Watch have been providing weekly case updates like these that give you highlights of key cases in both the federal and state judiciary that are shaping the scope and use of public health powers. Next slide, please. This is a nice summary with a QR code to the journal article for more detail of the studies that Wendy Parmet and her team are leading in this space. The bottom line that I've taken away from the Public Health Law Watch team is a mixed bag of good and bad news. The good news being that public health actually wins most of the time. The bad, and if I'm honest, quite scary news, is that we've had some key losses, especially in federal courts and at the Supreme Court itself, where all courts look to for guidance. You can get some good detail about the doctrinal law areas where that's happening in this article here. Next slide, please. Another great way to get a quick overview of the learnings from Act for Public Health are the fact sheet type resources like this one from our colleagues at ChangeLab Solutions. Their fact sheets distill down learnings, drawing from both the legislative and litigation tracking, and using practical examples to better understand the impact. Next slide, please. Our friends at ChangeLab Solutions are also helping to lead Act for Public Health's efforts towards a more harmonized response and legal framework to that well-coordinated backlash effort I mentioned at the beginning. The network's innovations report shown here on the left is one of the many inputs going into that effort. And I highlight it here just to be able to point you all in the direction of concrete practical examples of bright spot laws and policies enacted during the onslaught of backlash to public health authority that coalesce around this idea of what well-balanced, evidence-informed and equitable public health authority might look like in practice. Some of what you'll hear about from our speakers is captured in this report, and there are many, many others across the geographic and political spectrum that we've tried to identify as well. So if you're looking for some hope and inspiration or just ideas of things you could be working on or could try to advance or others you could talk to, please check out the report. Next slide, please. You can find all of the resources and more that I've just run through on the Act for Public Health website. And while you're there, I would also encourage you to join our email list. And of course, feel free to reach out to any of us for assistance. So with that, I will turn it over to Jeff to take the reins from here.
All right. Thank you, Darlene. Can everyone hear me okay?
Yep, I can hear you.
Excellent. Thank you. And thank you for the invitation to join this great panel of speakers. I'm really excited to be here. Really excited to speak to all of you about NACCHO's policy statement on public health authorities. And so just to introduce myself, my name is Jeff Mangulu. I'm Director of Law and Policy at the National Association of County and City Health Officials. I've been at NACCHO for 10 years in September. Time flies by when you're very busy. And, I'm excited to continue my work at NACCHO. Started in the preparedness realm, in the public health law realm, and that led to the public health law realm, where we've been able to build this program that's supporting the law and policy efforts of our local health departments. Next slide, please. So for today's presentation, what you see is an outline of what I plan on going over. Briefly, who is NACCHO, discuss our policy and advocacy work over here at NACCHO, and then provide some information and insight on our policy statement related to public health authorities. Next slide, please. All right, so who is NACCHO, the National Association of County and City Health Officials? You may have noticed I said NACCHO, not Nacho. No worries if you thought it was Nacho. You're not the only ones. I would say probably 95% of folks pronounce it Nacho the first time. But next slide, please. So we are a member organization, an association. We represent 3,100 local health departments, or over 3,100 local health departments across the United States. Our mission is to improve the health of communities by strengthening and advocating for these local health departments in a variety of ways. Next slide, please. And so when I say that we support our local health departments, we look at how we could support them through our advocacy efforts on the Hill, with Congress, at the federal level, and also how we can support local health departments within their own jurisdictions. We also help health departments put together partnerships to move forward with their public health efforts, because we know that many of the public health interventions that we want to take part in as public health professionals require multi-sectoral partnerships. In addition to that, we provide funding to our local health departments, training and education, networking opportunities through our conferences. That is a nice segue to the fact that our annual conference, NACCHO 360, is taking place in about 2 weeks in Detroit. We have 3,500 folks going there. It's actually the largest NACCHO 360 that we've ever had. And so if you have not registered, please feel free to do so. And in addition to all those other efforts and activities, we also provide resources, tools, and technical assistance to our local health departments in a variety of different topic areas. Next slide, please. All right, and so our focus today is on our advocacy and policy efforts, primarily our advocacy efforts, and that's leading to our policy statement related to public health authorities. Next slide. So we try to serve as the voice of local health departments. And how do we do that? We have a board of members from local health departments across the country, and other partner organizations are able to participate on our board as well. And this board sets our legislative priorities, as well as helps us to define our voice in a variety of different topics, stating our position and kind of the direction that we would like to take in terms of where we think local health departments gain the most benefit and gain the ability to be better able to do their work and exercise their expertise. On the screen here, you see a list of our 2024 legislative priorities. And our next slide, just go to the next slide. It's a description of how we come up with those priorities and how we come up with our actual statements on those different areas. And so what is a NACCHO policy statement? So a policy statement is kind of a concise statement of our stance on an issue. It serves as a call to action. It allows us to describe kind of our position on a variety of different public health topics and clearly be able to convey that information to Congress and to our members, who are then able to utilize our policy statements for their efforts within their jurisdictions as well. This is to support advocacy work. We don't lobby. We're a nonprofit organization funded by many federal programs. And so we provide education to folks who are creating the laws, who are lawmakers. And so these policy statements provide us with that consistent message that we're able to provide to those lawmakers so that they are better able to understand the issues and the nuances and how they impact our local communities. And how do we develop these policy statements? So NACCHO has a number of advisory groups. We like to call them work groups internally, but they are advisory groups that are made up of folks who practice in the field at local health departments. Folks are able to apply for these work groups once a year, and they're able to participate in these work groups and create policy statements and create other tools and resources that they think can support our local health departments. Once a policy statement has been identified as a need by our work groups, they are then put together by staff and the work groups and then presented to the board, who is able to then review and make modifications where necessary. After that review takes place, that becomes NACCHO's official stance on that topic. These policy statements are reviewed every 3 years, and in that way, we're able to update the contents of those policy statements based on the changing field of public health. And so, as mentioned, we primarily use this to communicate with Congress through our government affairs team internally at NACCHO, and our members utilize it to convey kind of their stance if they do want to take a similar stance, or use it as a model for any other kind of approaches they want to take related to the topics. Next slide, please. So with respect to our policy statement on public health authorities, we put this together because we saw that there was a need by the field. Our members requested that we put this together, and we wanted to add another independent voice to the chorus of organizations who are acting on the need for support of our public health community, Act for Public Health, and other entities as well. Next slide, please. And so what are our positions? So NACCHO supports policies that allow public health officials to protect their communities, as opposed to what we have frequently seen, unfortunately, that being the opposite, where we're seeing a lot of policies and laws being put in place that remove the ability of public health officials to support and protect their communities. In addition, NACCHO supports legislation which affirms that public health authority is granted to public health officials. And so by that, what we know, or what we hope to see, is additional legislation that more firmly emphasizes that health departments, public health authorities, public health officials are those entities that we trust to provide us with the best decisions and the best actions when it comes to a public health situation. If there's a public health response or if there's a public health emergency, we look towards our health officials. Just want to make sure that the lawmakers are putting in place policies and laws that add clarity to that fact and then support that fact if necessary through a variety of different ways. Next slide, please. And so how do we justify that position, those positions? These next slides kind of go through the different ways that we justify kind of our approach to our policy statement. And I should have said this in the outset, but you can find all of our policy statements, including this one. And I think I mentioned this briefly, but if you go to our website, there is an About section that includes information on policy and advocacy. That includes all the information that we have related to policy statements, as well as how to properly advocate if you are one who participates, works in governmental public health. And to jump back into our policy statement here, our first justification is that authority allows for preparedness in the face of crisis. And so we all know that many of the restrictions that we're seeing come across are the result of response to public health's role to the COVID pandemic. And so oftentimes these reactions are short-sighted, and folks aren't really noticing the fact that they may be impacting more than just the response to the COVID-19 pandemic. As we've seen in the past, public health, the acts of public health officials and public health staff have done an amazing job in mitigating the risks and mitigating the impacts of a variety of different infectious diseases. Not only COVID, where we found that the action slowed and drove down transmission. H1N1 is another recent example where we noted that public health actions prevented 5 to 10 million cases of H1N1 and reduced hospitalizations by 30,000. We also, notice this when it comes to Ebola and other infectious diseases, as well as when you're thinking about just public health response to a variety of different emergencies, natural disasters, etc. And so we see that local health departments may be impacted by restrictions on their authority as you look towards the future of public health response to a variety of different disasters, emergencies. And we'd like to see that local health departments are able to respond to future-facing emergencies, hurricanes, flood emergencies, heat emergencies, and continue to do their work to support their communities. Next slide, please. Also, authority allows public health to reduce preventable deaths. I think that this audience is very well aware of the fact that public health and the policies that support public health have had a big role in reducing many preventable deaths, especially in the 20th century. I think many of us are aware of the impacts that vaccinations have had, as well as motor vehicle safety, tobacco control, all the different ways that public health policies have impacted our lives have done a great job of reducing preventable health deaths. And so if there is a restriction on authority, or if authorities are restricted, it's more likely than not that we'll see many of those preventable deaths and the advances that we've made in that area start to ebb away. Next slide, please. Authority enhances access and equity in healthcare. So public health interventions oftentimes benefit everyone. Public health, focuses on prevention and preventing negative health outcomes. And so when you're looking at activities such as lead abatement, as you're looking at activities related to environmental justice, you see that there are impacts that go towards prevention that often impact not only those well-resourced populations in our jurisdictions, but also those that are low-resourced as well. And so reducing the ability of health departments to be able to address those issues will further remove those protections that those communities have. In addition to that, many health departments also provide clinical care. And if there's any legislations that reduces the ability of health departments to be able to provide that clinical care and serve as that quote unquote safety net, you'll see some jurisdictions, populations within jurisdictions having less access to clinical care. And that doesn't just impact densely populated areas, but also impacts rural areas as well. Next slide, please. Local health officials should be able to perform their roles without fear of harassment or other unwarranted ramifications. And so many of us know, I think all of us probably know, that the response to COVID-19 brought about many threats to not only local health officials, but also their staff. And so it is our belief that affirmation of the role of health officials of public health in response to public health emergencies should help to mitigate some of those threats due to the clarity provided, especially if clear penalties are involved and are expressed in those affirmations. Next slide, please. Public health decisions should be evidence-informed and free from political pressure. And so this just notes that local health officials should be able to make their decisions quickly, clearly, for their jurisdictions based on the evidence and not based on any political kind of bias that there might be out in the field. And so we just really want folks to understand that health officials should be able to act independently. Of course, there might be nuance that could be provided by political appointees as they are the voice of their jurisdictions, but those decisions that are being made at the public health level should be made based on the evidence. Next slide, please. And so again, that is the presentation. You just see the slide here, just presenting kind of summary of what we just went over. Last slide, please. Again, want to thank you all for taking some time to listen to our message and this summary of our policy statement on public health authorities. You can reach me at the contact information displayed below. And Darlene, I'll hand it off to you if there's any questions or anything else.
Yeah, thank you, Jeffrey. That was great. And thanks for providing some examples of types of things you're talking about in your policy statement. I think that's really helpful. And folks should feel free to reach out to Jeff. You've got his email here if you want some of those more specific examples. We do have a few questions, and I think you covered this already, but I think it's helpful to just reiterate for folks who the audience for the policy statement is. The specific question is it members of Congress?
Got it. Yeah, so our audience includes members of Congress, includes the general public, includes their members. Really is a message for everyone who is interested in this topic. Our policy statements serve as providing the perspective of local health departments. At least that is the belief that we have and we're able to come to that conclusion based on the way that we come up with our policy statements, as well as the approval process for those policy statements. And so if anyone wants to hear what local health departments think about a specific topic or issue, they could look towards our policy statements. I did note in my presentation that our government affairs team uses these policy statements as the core of their message to folks in Congress, but anyone could utilize this information as evidence of what local health departments and NACCHO especially think about certain issues. So you can use it in any way that you would like. It's our public facing message to the world.
Thanks for that clarification, Jeff. There's another question about the mention of STILT, state and tribal, local, territorial, at the very end of the policy statement, but this attendee notes that there's no mention of tribal data sovereignty or tribal epicenter public health authority throughout the document, and they're wondering if there are any plans to add this information later.
Yes, we are doing what we can to further support our tribes and those folks who serve our tribes. Our intent, hopefully in the near future, we'll see if we're able to do so, is to be able to provide messages that are more focused on the needs of our tribes in the future. I would say that we approach this policy statement as a broad policy statement that we hope can support all communities. However, there are some points, there are some issues that are unique to the needs of tribes. And I think that those points and issues and those conclusions are better served in a separate policy statement. So we'll continue to work with our tribes, continue to work within our work groups to better be able to address the needs of the tribes and be able to provide further information, further guidance for those jurisdictions. That's a great question. Thank you.
Thank you, Jeff. For the sake of time, I'm going to encourage anybody else who had a specific question for Jeff to email him. Again, you've got his email address here. And we'll turn it over to Sarah next.
Good day, everyone. Can you hear me?
Indeed, yeah.
Thank you. My name is Sarah Lochner. I use she, her pronouns. I am the executive director of the Oregon Coalition of Local Health Officials. We are the SACHO in Oregon. And just a tiny bit about me, I have spent the last 20 years working for elected officials, state and local governments, advocating for advancements in policy and funding to address health inequities. And with that, we'll get started. Next slide, please. First, I wanted to give you just a little bit of background about Oregon. We have a decentralized public health system. We have 36 counties and 33 local public health departments that are generally county-based. We do have some challenging geography. I included this map, even though it's hard to read. The vertical text you see on the map are mountain ranges. And Portland, Oregon, which is our population center, is at the top of the state in the little dip kind of on the left-hand side. And then below Portland, between the two mountain ranges, is the Willamette Valley. That valley is really where the bulk of our population resides. And then on either side of the mountains, we have rural and frontier Oregon. These communities tend to be very isolated, especially in the winter when traveling over the mountains is very treacherous. So these communities tend to be very independent and generally just very isolated. So that'll come up later a little bit more. I also wanted to mention that our state legislature operates on a biennial budget process, meaning we get funded every 2 years, and they have to adhere to a balanced budget every 2 years. So we have the opportunity to fund additional public health programs like public health modernization or transformation, as you might call it, every 2 years. And Oregon was one of the early adopters of public health modernization, one of just a handful of states. And then before we go any further, I have included a list of acronyms here. We call our local jurisdictions local public health authorities, LPHAs. The Oregon Health Authority, OHA, is our state regulator and our state agency. We'll be talking a little bit about community-based organizations, CBOs, typically a 501c3 structure or a nonprofit. And then also my organization is called CLO, the Coalition of Local Health Officials. And with that, we can move on. Thank you. Some context about public health modernization in Oregon. As I mentioned, Oregon was an early adopter. It started in 2013 with the Task Force on the Future of Public Health, and then progressed to 2016 when we did an assessment as to how much fully implementing public health modernization would cost for government public health. And we arrived at $210 million per biennium to fully implement. We do believe that assessment is outdated at this point. So local public health and OHA are in the process of recosting out what it will take to fully implement. Because as you all know, we've experienced significant inflation and changes to our economy over the last several years. In 2017, the Oregon legislature invested $5 million in public health modernization. Then again, in 2019, $10 million additional was invested. In 2021, we finally got a significant investment of $45 million for public health modernization. You know, it took a global pandemic to get them there, but we got there. And at that time, the Oregon Health Authority added community-based organizations to the direct awardees list out of that pot of funding. And then in 2023, we succeeded in getting an additional $50 million for a total of $110 million per biennium. $50 million of that goes to local public health authorities. And when you divide that by 36 counties, you can do the math on how far we've come. We've made some progress, but we're not even halfway there. I anticipate the new assessment that we're doing will probably come in somewhere around $300 million, but we'll see what it turns up. Regardless, we are 10 years, more than 10 years into this process. We're halfway-ish funded when we should be fully funded at this point. So we have had to scratch and claw our way to get this money. So local public health is a little road weary, but they are committed to seeing this through. Next slide, please. So Oregon's big experiment. In 2021, OHA directly funded community-based organizations, braiding several sources of funding together to create a pot of $30 million that they called the Public Health Equity Funding, for which community-based organizations could apply. through a grant process. And modernization was one of these funding sources, along with ARPA and some tobacco tax dollars. So they got quite a significant funding pot here for that first round of funding. And while local public health in Oregon strongly believes in the value of community-based organizations as partners in our public health work, this method has achieved some mixed results. And some of the criticisms around the way this was done was that it bypassed local public health's input, and it really didn't coordinate across local public health. We'll get into a little bit of that more detail. Historically, local public health has been the entity that would contract with CBOs for specific projects that align with their community health improvement plan. And this initiative by OHA really kind of usurped the role of local public health in doing that, and sort of, I guess, made it a little bit harder to do that community partnership development, which is a foundational capability that local public health has in statute. The grant making process was not transparent, and the public health modernization dollars are supposed to be a statewide resource. And one of the challenges with a grant process is that you can't control who applies. And so what ended up happening is that the applicants were not evenly distributed throughout the state. And so the population centers in Oregon ended up getting the vast majority of the funding, kind of leaving rural Oregon behind. Also, there was a lack of CBOs that applied in the disability space, and that was also a big gap that we found. There were regional and statewide organizations that were funded to do work in multiple jurisdictions throughout Oregon. However, they did not have an existing presence in some of those communities, or knowledge of how to operate in some of those communities, and that became a shortfall of this initiative as well. Oftentimes they ended up just serving a portion of the communities they intended to serve, which then further increased the gaps in folks who got served and folks who did not. Coordination between local public health and CBOs serving their jurisdictions was challenging if they did not have a pre-existing relationship. There was confusion about who should reach out to who, how to align the work and collaborate, and what to do if an organization that you reached out to didn't respond. Some additional anecdotes that I've heard from my members, that sometimes grant projects were approved that were duplicative of work that local public health was already doing. Or in one particular case, a CBO was funded to do a project that they didn't have the specialty workforce to accomplish. For example, they were funded to do vaccines in senior centers, but they didn't have the proper licensed medical staff to do that work. And then they tried to get local public health to do it for them. So that, as you can imagine, went over like a lead balloon. So I do want to acknowledge how we got here. This was born out of the pandemic response. We all worked together, and OHA directly funded CBOs during the pandemic response, and great work was done. And so the thinking was probably, well, we did it for the pandemic response, let's try it with other projects. And it was born out of the Black Lives Matter movement, which created a huge sense of urgency to be part of the solution as fast as possible. But part of the problem is that we were all still in the middle of a pandemic, and there was a lack of capacity on OHA's side to host a stakeholder engagement process, and there was a lack of capacity on local public health side to participate in a robust stakeholder engagement process. So it was really the perfect storm of trying to do something quickly and it not going exactly according to plan. In addition, OHA their leadership and the vast majority of their staff are located in Portland. And they really don't have intimate knowledge of every community across Oregon, who their CBOs are, what their capacities are, and what specific projects local public health needs funded. And that would be virtually impossible to know, which is why it's so incredibly important to include local public health or let them lead this work so that that intimate knowledge is there and that the coordination is there. And just by virtue of population centers having a larger number of community-based organizations than rural communities, there ended up being a very urban focus for these dollars and the CBOs that were awarded, leaving a lot of other communities behind. And I do want to acknowledge that the Oregon Health Authority had very good intentions with this initiative. They have a big, hairy, audacious goal of eliminating health inequities by 2030, and this was their strategy to attempt to do that. Next slide, please. So after 2 years of conversations, beginning in 2021, really rehashing and reiterating the shortcomings of this process, CLO and OHA finally reached a compromise agreement in writing for a better process for the 2023 round of funding. As the first step to implementing this compromise agreement, in May of 2023, OHA brought together a group of local public health and CBO representatives to work through the details of what the application process should look like moving forward, and what the application requirements and the review process. They ended up deciding that there should be a focus on locally based CBOs. So again, not having some outside, hundreds of miles away group say that they're going to come serve your community, and try to focus in on those that have some sort of presence in the community. And they did that by requiring 2 letters of recommendation as part of the application requirements. And it was encouraged that one of those letters be from a local public health department. The group also decided to use a funding formula that was largely population-based to establish targets for fair distribution of the funds throughout the state. They also agreed on improving coordination through work plan sharing. So OHA has created an online dashboard where all the work plans are uploaded, and local public health and CBOs can see each other's work plans there. And then we also negotiated some technical assistance and training for both local public health and for CBOs. We found that many CBOs don't really understand public health modernization. It's a foreign concept to them. And so we wanted them to understand the framework that they were operating in, hoping that that would improve the public health knowledge that they have. So please move to the next slide. So the challenges do remain with this round of funding that just went out. We have still found that 8 out of the 33 local public health authorities were still underfunded for this round due to lack of qualified CBO applicants. And again, that's because some communities are so small that they don't have CBOs needed to do this work. So, like one Oregon county, for example, has 1,200 residents. And so you're not going to have a lot of CBOs in that community. We are still grappling with how to measure CBO success, how to really measure those health equity outcomes, and whether or not to include CBOs in accountability metrics. It's complicated, especially when they're doing 2-year projects to really show outcomes. And we will continue to iterate on this process and push for improvements, specifically that geographic equity piece. We know that there are folks with health inequities in every community, whether it's Latinx farm workers or unrecognized tribal members. So it's important that every Oregon community have access to this health equity funding. Urban areas tend to have a lot more resources for this, and so we want to make sure that no one is left behind. And throughout all of this process, I just want to say that our OHA partners have really stepped up and been good collaborators the last several years to help improve this process, and we look forward to continuing that work and continuing the collaboration. And lastly, I'll say that I do have hope for how this is going and that we can continue to make progress. It has been messy and hard and has involved a number of difficult conversations, but I believe that it's been worthwhile. Next slide, please. I just wanted to leave you some links in the slides to some success stories. I talked a little bit about some challenges, but it's, you know, we've had some really great successes as well. So if you are so inclined to do some additional reading on the topic, when these slides come to your inbox, you'll have links to read more. Thank you so much. That's all I have.
Thank you, Sarah, for some really thoughtful discussion on, as you said, some tough topics and discussions to have. There's some chat in the chat box that I, get at some of that tough discussions and that rural sort of leaving behind concept that you described. And I think there's one question that I think kind of gets at the heart of some of this tension as well. One of the attendees asks about recent public health overreach has understandably contributed to a loss of public trust in our profession and in the authority previously provided to us. So in this context, recent curtailments of our authority are a reflection of the public's loss of trust and can be viewed as a referendum on our performance. Do you think this perspective considered is valid?
Yes, I do. And in the context of my Oregon experiment, I think, to be honest, I think the trust in the state government was eroded a little bit by this initiative because, Oregon is mostly rural, and when communities get left behind or left out of the funding opportunities, their communities are not served. And so I do think that the erosion of public trust is what we're trying to build back right now and work with OHA to build that back. Yeah, great. Okay. Again, for sake of time, I'm going to help us move along, but there are some specific questions for you, Sarah, if you get a chance in the Q&A and again in the chat too. All right. Thanks, Sarah. Patrick, you're up.
Wonderful. Thanks. Can you hear me all right?
Indeed. Yeah.
Great. Well, thank you. Thank you all for having me. My name is Patrick Brown. I'm the Executive Director of the North Carolina Public Health Collaboration. The collaboration, as you'll hear me reference it probably for the rest of my few minutes with you this morning, is a convening of 3 public health advocacy organizations in North Carolina. So we run the North Carolina Public Health Association, which is our overall professional association representing sort of all public health professionals. That would be our state chapter for APHA. We run the North Carolina Association of Local Health Directors, which is basically, you just heard about Oregon's local public health work. So we also represent North Carolina's local health departments through that organization. And we also operate a third nonprofit, the North Carolina Alliance of Public Health Agencies, which is a third agency, sort of a shared services arm that runs a staffing agency and provides a few other services to our local health departments that help us sort of run our entire organization. So all 3 of those are strategically aligned with shared staff, shared resources, and a sort of shared strategic direction. I will be mostly wearing my Health Directors Association hat this morning as we talk about some advocacy work we did in North Carolina, specifically legal advocacy, which was a new venture for us, and I'll share a little bit of those perspectives. I'm realizing I should have put a slide similar to that sort of background context that you heard from Oregon, but North Carolina, large state, 100 counties, 86 health departments that cover those 100 counties, 80 single county health departments, and 6 multi-county districts. So we do also have a decentralized public health model. Last disclaimer and context I'll give before I move into my few slides is I am super not a lawyer. I'm a pharmacist by training, sort of accidentally got into public health during COVID response and have been in my role for a little over a year and a half now. This is something that came up pretty early in my tenure in my role as executive director. So I'll share my perspective, our perspective, and then some thoughts that may be relevant to you all as if you are ever considering sort of the legal advocacy route. So with that, we can jump into my first slide. So the backstory here, this is a legal case as it relates to COVID era actions and efforts to mitigate risk during the COVID era. So the lawsuit in question, and the thing that I'll talk about and I'll frame up to you all is the lawsuit here. You'll see Kinsley versus Ace Speedway Racing. Kinsley, that would be Secretary Cody Kinsley, who's our current DHHS Secretary in North Carolina. This all actually dates back to the COVID days when Dr. Mandy Cohen was our Health and Human Services Director before her current role as Director of the CDC. I was actually working at the Department of Health and Human Services and specifically in the Division of Public Health during a lot of this time. So these are people close to my heart and work close to my heart as well. The legal case in question, and I am going to give you like the layman's non-lawyery explanation of how I understand this case, and Darlene maybe or others can come on mic and bail me out if I say something incorrect. But this case in question centers around Ace Speedway, which is an outdoor racetrack in Alamance County, North Carolina. Alamance County is sort of central North Carolina, is a sort of one of our mid-sized counties, pretty rural, but not super tiny, pretty close to Greensboro, right in the middle of North Carolina, which is, if you're not from North Carolina, about halfway in between Raleigh and Charlotte is kind of the best sort of frame of reference I could give you. During early days of COVID, the Speedway was continuing plans to operate mass gatherings via events at the racetrack, 1,500, 2,000 people events at the racetrack. There were steps taken to try to stop that from happening over fear for spread of COVID during that time and the health risk to the community that would happen, including abatement orders issued and a court order by Secretary Cohen at the time to shut down those operations after the abatement order was not followed. So operations did shut down at the time following those actions. In follow-up to those actions, the Speedway challenged the department, claiming both that the actions violated the owners of the Speedway's rights to earn a living and equal protection. They made some arguments that they were singled out for this action compared to some other things that may have been going on in North Carolina at the time. This case has made its way through several efforts. There were some appeals and some attempts to sort of get the case dismissed, but it did make its way all the way up to the state Supreme Court, and arguments were heard on November 7th of 2023. We are awaiting decision on this case. It has been, as you imagine, quite some time since arguments were heard, and I don't have a real much of an update on decision, but that is sort of that's sort of the high level overview of the case in question. So if you'll move into the next slide, I'll speak briefly to sort of our role in this and how the North Carolina Association of Local Health Directors came involved. So basically, as it was sort of identified that the case would be heard by the state Supreme Court, we were contacted by the legal team with the Department of Health and Human Services, as well as the state solicitor general staff and the attorney general and the team that would be defending the state in this case, basically encouraged to jump in the fray via an amicus brief to take action. So I'm jumping down to the bottom here to give you general definition of what that means. If you're not familiar with it, I imagine if you joined this webinar, you're probably pretty familiar with that process, but I barely knew what it was when we were asked to do it. So I figured the definition be helpful. So, you know, that Latin you see there means friend of the court, and the general idea, and you can see the reference here where I pull this. The general idea is in a lawsuit or in a court case that a party not named in the case, that is not either plaintiff or defendant, can file a brief sort of sharing a thought on the case, saying, hey, we are not party to this actual case, but that we have a vested interest in the outcome, and we are sharing with the court what we think related to the case. So basically, we were asked by the department to jump in here and to weigh in. And the framing that we sort of took up, and the reason we were sort of involved in this, was over fear of this right to earn a living piece, and specifically related to financial damages that may have come from an action to take public health action to shut down a business, an entity, or whatever that was doing something that may have had a public health risk. And so we were approached in March, asked if we wanted to be involved in this. We scrambled rather quickly, got a law firm involved, and did decide to go ahead and file a brief. Our reasoning to decide to file a brief here was over fear of liability resulting from a decision in this case, should a local health department in North Carolina have to act on a restaurant that was acting in an unsafe way, a swimming pool, a tattoo parlor, an operation where an on-site wastewater system, a septic tank, a well was not properly functioning, and there was public health risk, that there would be financial risk and liability to the health department and to that county government from taking that action if precedent was set here, and also for a chilling effect for local public health authority to act for fear of that type of liability. You know, and would there be health risks if, you know, counties, local health departments were sort of afraid of acting because of that financial risk. So we found a law firm, you'll see the name here, Teague Campbell, a few weeks later, and got a brief filed basically in a month from the start of it all. And you can see here in the link, you can see directly to the brief itself. If you'll move on to the next slide, I'll share some sort of perspectives and lessons learned from our process. You know, I think our lessons learned and how I would branch that over into future considerations for anyone considering this. We did not know really anything about this process when we went in, so we had to learn a lot pretty quickly. We did reach out to some partner organizations, to NACCHO, ASTO, I would share. ASTO also filed a brief in the case, and so we were great to see a national organization step in, sort of supporting our claim here as well. We did not have time to sort of engage any kind of pro bono support in this process. It was a very tight turnaround. We got pulled in late. We decided to act late. And so basically we kind of had to decide to foot the bill for this thing. And as you can imagine, if you want something like this done and you want it done quickly and well, it can be pretty expensive endeavor. So, you know, that was one thing we learned. We were fortunate to be in a position where we did have a legal reserve fund for our organization. So we had the funding to do it. Not all of our contemporaries, our SACHOs, are in that position, either because of their size, their budget. There are some SACHOs, some state associations of city and county health officials that aren't even sufficiently funded to have full-time staff. So that was, you know, a position in North Carolina where we were lucky to be, and we were glad to be able to be, so that we could advocate on behalf of our members. If you were to decide to sort of try to get into this type of legal advocacy as it relates to filing briefs or engaging in this way, I would encourage organizations, you know, to consider, like, is this something you want to do? Is this something that you want to have part of your advocacy mission, or would you rather focus on legislative advocacy, local government advocacy, whatever it may be? If you do, it may be worth thinking about a legal reserve fund and trying to consider fundraising efforts or diverting some resources to setting up a fund like that so that you can act if you need. It also is probably a good idea to think about who your pro bono partners would be and how you could get in contact with them if this opportunity exists. If this comes up again, I know much more now about the network and those supports available. So that would be the first call I would make, and we would know to act a little quicker in that regard. That was one of our big lessons learned. The other thing I'll share is just, if you want to be involved here, keeping an eye out on what's happening in your state, locality, region, whatever your sort of area of service is valuable, so that you maybe can know about them sooner and have more time to act. So that was a very high level, very quick overview. I am happy to answer as many questions as possible. I will advise, as I close, I'm not a lawyer. So if there are questions about the case in particular, I probably can't answer them, but I will do my best. And thank you all for having me.
You did a great job, Patrick. It's a complicated case. You've mentioned, you felt like y'all acted kind of late. Do you have a sense of like how many more months would have been helpful for you, for example, to be able to feel like you could have done this without the panic maybe that ensued when you got the request? I know Active Public Health Partners and others are thinking through, right? Like, at what point in a case would it be nice to be flagged for folks that might be interested in this type of advocacy?
Yeah, it's hard for me to definitively say for sure on the like pro bono side of it, because the answers we got at the time, and very understandably, like I would not expect anyone providing pro bono support like that to be able to say, yeah, we can get this thing done in 3.5 weeks for you, which is effectively what we had. I feel like for my case, even if I had 2 to 4 more weeks to take a breath, ask a few more questions of the firm we were going to work with, call around to some other folks across the country who may had done this in the past through this network, through the SACHO network, through APHA networks, et cetera. Maybe an extra 2 to 4 weeks would have been helpful. So I don't feel like we needed 6 months, maybe 2 instead of 1 would have been really nice. Because basically with the time we had, I reached out to our members and I said, hey, are y'all working with law firms on anything right now where you think they might have someone? And I got 2 names that way. And I reached out to those 2 names, and one firm said, yeah, we probably can help you with this. And then we went sort of in that regard. So that was kind of how that all shook out.
Thank you. Very helpful. Okay. I'm sure we'll have more discussion afterwards. So we'll turn it over to Joelle now, bat and cleanup.
Thanks, Darlene. It's been just a pleasure to listen to all the speakers today. I have a lot of thoughts on what everyone is working on, but I'm really happy to be here to talk about the importance of local authority and what we can learn from commercial tobacco control laws and policies and the behavior of the big tobacco industry. Next slide, please. So I'm Joelle Lester. I'm the Executive Director of the Public Health Law Center. We're based in St. Paul, Minnesota at Mitchell-Hamlin School of Law, which is situated on the traditional homelands of the Dakota people. This is a snapshot of our incredibly talented, funny, and kind staff. We have many, many public health lawyers, a few policy analysts, and an incredible administrative, financial, and communication staff supporting the work that we do all around the country. Next slide, please. So we work generally in public health law related to chronic disease prevention. We started, and our biggest program is in eliminating commercial tobacco. We also work in promoting healthy food access and physical activity. We do a lot of work across all kinds of public health issues with tribal public health leaders. And our newest program, but 3 years in, is working to advance climate justice. So we do all of this work with the idea that everyone deserves to be healthy, and public health and community advocates and public health department staff need the legal expertise to design effective laws and policies that will achieve their public health goals and withstand the inevitable industry litigation attacks. Next slide. It's really important to think about how we center equity in our work. This graphic is thanks to the Robert Wood Johnson Foundation, but we really strive to think deeply about avoiding unintended inequitable consequences of public health policies and avoiding exemptions that leave some segments of communities outside of the protection that we are trying to extend to all members of a community. Next slide, please. So I'm going to talk a little bit about preemption. We do a lot of work in a lot of areas, but one common thread throughout is preemption. And to the questioner earlier who talked about the kind of loss of confidence and trust by the public in public health infrastructure during the COVID-19 pandemic, that is a real challenge that we are facing in public health, and we need to figure that out. And I would add that attacks on public health authority to act have been a part of the industry's arsenal for decades. So trying to delegitimize or just flat out prevent governments and community advocates from changing policies to protect health is a time-worn tactic of the tobacco industry, and many other industries take a page from the tobacco industry's playbook in implementing that. So just briefly, preemption is the order of authority, so federal law being above state law and above local law. So the so-called higher level of government action can prevent the lower or nullify the lower government action. And it's not, the federal government can't do anything it wants. Of course, its authority flows from the US Constitution, and there are limitations on that authority in the US Constitution. And then states often delegate authority to local jurisdictions, but often there are also some authorities given to the local jurisdictions in a state by the state constitution. So again, that's a situation where the legislature can't overcome what's in the state constitution. So there's a little bit of saying who can do what, but generally speaking, it's a tactic of many industries to try to use a higher level of law to prevent effective public health policy change at the other levels. Next slide, please. So this is really important because local jurisdictions and states serve as the laboratories of democracy. And as we know, this is very true in commercial tobacco control, but it's also true in other issue areas as well. The locals lead the way. The federal government certainly has never led the way in protecting health from commercial tobacco products, and actually didn't really even get into the game until Congress delegated authority to the FDA under the Family Smoking Prevention and Tobacco Control Act of 2009. But this is, the local governments especially tend to understand what the community needs, see the harms caused to the community of the different products that are on the market or other causes, and then act. And the authority to act has been central to our success in commercial tobacco control, in healthy food access. And so it's really important to public health generally to protect that local authority to act and state authority to act. Next slide, please. So these are just additional statements in support, but I will call your attention to this. You know, it's a recognized, federally recognized value that state laws that preempt stronger local public health laws, or in this case, commercial tobacco laws, are problematic for public health. So we'll talk about why in just a minute. Oh, please go to the next slide. So why should we care about local authority versus state and state versus federal? We know that the community level is the decision makers are most reflective of the community, and as levels of government get further away from the community level, they tend to be less reflective of that community. People have relationships with policymakers in their communities. They know folks who are on school boards, and they know folks who are on the city council. They are able to attend meetings. The geographic barriers don't exist in the same way as they do for traveling to a state capital or to Washington, D.C. And we know that the community is better able to design the policies to achieve equitable outcomes for all members of their community. And I think that in all areas of public health, we're always in danger of designing a good policy that only delivers the health benefit to the already most privileged members of that community. And so it's really important to have the folks who are affected by the policy weighing in. And it's helpful for designing the policy. It's helpful for thinking through implementation and equitable enforcement, the practical details that translate the idea of the policy into operation and into the health outcomes we're trying to achieve. Next slide, please. So the big tobacco industry has long used preemption of local authority to act as it's an explicit objective of the industry. You probably know the photo from the left is from a congressional hearing in the mid-1990s, where all the CEOs of the big tobacco companies swore under oath that they didn't believe nicotine was addictive. So everybody in tobacco loves to use that photo because it's a picture of the liars just lying right through their teeth. And they would rather deal with the federal government than 50 states, and they definitely rather deal with the 50 states than hundreds and hundreds of municipalities. So it's been part of their plan. And these quotes were taken from the documents archive that's housed at the University of California, San Francisco. So it really is, it's from their own internal documents. It's how they talked about preemption and why it's important to them. I would also just add that I was recently chatting with a colleague, Andrew Tunamatsiko, who works at the O'Neill Institute for Global Public Health at Georgetown Law School. And he used to work here at the Public Health Law Center, and he worked on tobacco for us. And now he works outside of tobacco. But he said everything he reads about, all the cases, all the pushback to public health protections, is the same tactics as what the tobacco industry has used for decades to try to hold on to their profits in the face of government action to restrict. And so I think it's really important that we look at how big tobacco has used preemption and attacks on local authority to understand what to expect from other kinds of industries who might want to resist other kinds of public health protections. Next slide, please. So I'm just going to give two examples of how this has played out more recently in the commercial tobacco space. So the first one is federal preemption efforts by the tobacco industry to try to defeat flavored tobacco product restrictions at the state and local level. So as I mentioned earlier, the Family Smoking Prevention and Tobacco Control Act was signed into law in June 2009 by President Obama. It gave the FDA some specific authority and some discretion to exercise authority over commercial tobacco products for the first time. The FDA has taken a long time to get some of these pieces in motion. And as you may also know, the FDA's regulation getting menthol cigarettes off the market, and as well as all flavored cigars, is still not final. And so this is 15 years of nothing happening. Well, a lot of happening, but nothing being final at the federal level. So in light of that, and while waiting for the FDA to act, many local jurisdictions started passing ordinances that would restrict or eliminate the sale of flavored tobacco products. This started in Providence, Rhode Island, and New York City, New York, and now has extended to more than 300 jurisdictions around the country that have different variations on the theme of restricting the sale of flavored tobacco products. And what the tobacco industry has tried to do is to argue that none of those jurisdictions have the authority to act related to menthol and other flavored tobacco products because Congress gave the FDA authority to regulate. And they have sued and sued and sued in jurisdictions around the country, starting with Providence, Rhode Island, and New York City, and several jurisdictions in the state of California, which had many local flavor policies before the state passed a law in the last couple of years. But the industry was using litigation with multiple goals. One is ideally to overturn the ordinance, to have the court throw it out saying that they don't have the authority to act because the FDA has that authority. But even when they kept losing the cases, they would still file. So for example, a community here in Minnesota, Edina, it's a suburb of Minneapolis, they passed an ordinance dramatically restricting the sale of flavored tobacco products, and they were sued by R.J. Reynolds. And Edina is not a big municipality, and they were very surprised to be on the radar of R.J. Reynolds. So it takes communities by surprise, and they don't want to sue. They don't want to litigate. They don't want to be sued. People feel very stressed and about the litigation. It's very expensive. These aren't huge communities often, and they don't have a huge litigation budget. And so the industry would also use that as a tactic to try to chill policy change by just making people afraid of the cost of defending against a lawsuit. So happily, in all of the lawsuits that the tobacco companies filed alleging federal preemption of these state and local policies, the state and local policies have been upheld. So that's wonderful news. And the jurisdictions have done a great job of defending themselves. And to Patrick's earlier point, many organizations have also supported those jurisdictions by filing amicus briefs in support. And we do a lot of amicus briefs, and we are always happy to help answer your questions or try to connect you with resources if you're interested, like Patrick was talking about, in getting involved. A more recent example is arguments about, well, first an effort to get state preemption and then arguments about it. So there are several jurisdictions in the state of Ohio, including Columbus, who passed flavored tobacco product sales restrictions as well. And in this case, after Columbus and I think a few other jurisdictions had passed these policies, the state legislature passed a law to explicitly prevent local jurisdictions in the state of Ohio from restricting the sale of flavored tobacco products. And Governor DeWine vetoed that bill, and the legislature overrode his veto. So Big Tobacco must have really invested in a lot of legislators in the state of Ohio. And what happened was, though, that in Ohio, the state constitution gives a lot of authority to the local jurisdictions to act to protect health and safety. It's a home rule state, if you've heard that phrase. So that's one where the local authorities have constitutional jurisdiction under their state constitution to protect health and safety. And some states are stronger than others. That really varies state by state. But in Ohio, the jurisdictions sued over the law, saying that the legislature couldn't restrict their activities to protect health in this way, and they won. So the law was struck down, and local jurisdictions in Ohio remain able to protect health in their communities by passing these kinds of commercial tobacco control laws. So those are just two illustrations. With the tobacco industry, you could go on and on because litigation is one of their favorite tools. But I will say in our climate justice work, we've seen a lot of similar activity, attacks on local efforts to decarbonize new construction through building codes or through city ordinances. And the industry has been suing, sometimes through front groups, to say that it's preempted under federal law, for example. So I think this is something for us to keep in mind as we work to protect clean indoor air in the case of the building decarbonization, clean air everywhere in the case of commercial tobacco, and all other kinds of public health issues. So I think I will stop there. Maybe there's one more slide, Leah, and turn it back over to Darlene. Oh, I do just want to mention that we are a resource. We have funding to support you in almost any way on commercial tobacco by providing free legal technical assistance. And then we have a lot of great resources on climate justice issues and healthy food access. And so if you have a question that we might be able to help you with, please don't hesitate to reach out. Thanks, Darlene.
Thank you, Joelle. And thank you for sort of weaving together all the different legal mechanisms in which y'all are functioning in that commercial tobacco control space. It's everything all at once, all the time, it seems like. And thank you for also drawing some parallels to other issue areas within public health that are experiencing some of the same local control issues. I'm wondering, so the one new aspect that you sort of raised for this panel is the proactive litigation from locals. I'm wondering if you want to say any more about that strategy or any more about issue areas or anything else in that space that if you want
Yeah.
to have a minute.
Well, I'm so glad you asked, Darlene. Darlene knows that we have been doing a lot of work to try to get the FDA to finalize the rule, getting menthol cigarettes off the market and all flavored cigars. And so it has been really important, instead of only thinking of ourselves as defending against industry litigation, to also think about how public health groups can use litigation to advance public health policy change. And so there are organizations led by the African American Tobacco Control Leadership Council, joined by Action on Smoking and Health, the American Medical Association, and the National Medical Association, who have sued the FDA for failing to act. So I think it's important because while the industry is trying to limit every government actor from policy change efforts that protect health and reduce their profits, we as public health advocates and leaders need to push every level of government to do what they can with the authority that they have. And in this case, the local jurisdictions and a couple of states have done incredible work to get the scourge of menthol cigarettes off the market in their communities, which is a policy option, if you don't know, that does more to advance health equity than almost anything else the FDA could do right this minute, given the tobacco industry's egregious historical and current targeting of the Black community, the LGBTQ plus community, and others. But anyway, so there's a lawsuit right now against the FDA, and I do think it's really important. I think that we have to think about how we use these tools as aggressively and relentlessly as the industries are trying to use them against the greater good.
Well, and I think with that, I'm going to invite every panelist to come back on screen for a little more discussion and Q&A with some of the questions we have in the remaining. So, Patrick, I see you would like to take the right to earn a living and access to resources question.
Yeah, sure. So there's a question in the Q&A. Taking away livelihood is very serious. Public health intervention and public health designations of some workplace livelihoods is essential. Or access to resources, vaccines, mass supplies is very serious ethically and politically. Completely agree. Very well said. I think the thing I would say around our stance, I won't speak for the state. I won't, speak to how they have sort of argued their case in this lawsuit that I was specifically speaking of. But what I can do is speak on behalf of my members around this. And North Carolina's local health departments know that the action to shut down a business is a very serious lever to pull and is only one to pull when it is absolutely necessary. And so it's not one that our members want to, use often and use frequently, because nobody wants to shut down anyone's right to learn a business. But real examples in our brief that we pulled from our members, when chemicals are wrong in a public swimming pool, or at a country, at a private club, and the pool is not right, and people are getting sick, or there's a Legionnaires outbreak because of a hot tub display at the state fair, and people are getting sick, or because sewage is backing up into the kitchen at a restaurant, you have to act to protect health. And our fear is less about commenting on the case in front of the court at all, and our fear is more about the precedent that could be set by a ruling to say, like, if I'm a small rural, all of our health departments in North Carolina are underfunded, but our smallest ones are the most underfunded. If I'm a small rural health department and a local restaurant has something going on that is harming the health of my communities, and I'm worried about a damages lawsuit to my county because I shut them down, and what do I do stuck between that rock and that hard place? That is the precedent that we chose to argue that is concerning and that should be considered.
Speakers, feel free to come off mute at any point if there's something else you want to add to any of the Q&A here. Joelle, are you able to take the Loper Bright? I don't know if,
Yeah, sure.
I'm guessing you've been thinking about it.
Oh, yes.
And if anybody else wants to talk about SCOTUS decisions and their impact to public health more generally, have at it.
Yeah, so monitoring the Supreme Court's activity on issues that affect authority to protect public health is something that all of the organizations Darlene introduced us to at the beginning of the call have been working hard at. For this particular case, the Supreme Court officially struck down what's known as the Chevron doctrine, coming out of an earlier Supreme Court case that established that courts should defer to federal agencies in how they interpret what they are supposed to do. So the delegation of authority from Congress to them, then they are the experts on how to figure it out and how to implement that authority. They have the technical expertise and the capacity to do so that far exceeds the courts. So now the Supreme Court said, no, that's not true anymore. And they have said that the courts are no longer required to defer to agency expertise and decision making. And this is problematic for public health. I think it's not that agencies are perfect. I lightly complained a few minutes ago about the FDA's slow pace of activity regulating commercial tobacco products, and I've been doing that for the last 15 years. But I do think that, you know, having researchers and scientists and the capacity to hold the public hearings and be out in the field and commission research is a really important function of federal regulatory agencies. And so it's concerning for all of us in public health, I think, to have any kind of limitations put on the federal agencies that house the expertise that we need. I would just add to that this is an industry-driven initiative to try to prevent the federal agencies from being able to robustly exercise the authority granted to them by Congress. And I think I would expect with big tobacco, as always, but maybe with some other industries, that they will try to make some hay out of this decision beyond what it should do for them. So I think we might need Congress to be more specific and explicit and comprehensible in its delegation of authorities to agencies to act. That's always something that members of Congress could do better anyway. And I think that's one proactive thing we can do. And then the other thing I would just mention, as I had said earlier, locals lead the way in public health, locals and states definitely before the federal government. And we have always known that we shouldn't wait for federal agency action to try to do the most we can at the state and local level to protect health in our communities. And I would say the Loper decision eliminating Chevron deference only underscores that further. We have a lot of tools to act to protect health in our communities. It's a reason we care about protecting local authority, and the Loper decision just highlights the importance of that.
Thanks, Joelle. Anybody else want to chime in on Loper or any of the other questions you've heard so far thrown out? If not, yeah, go for it.
If I'm not at risk of taking us right to the end, but there was one in the Q&A that I wanted to just chime in addition to the Oregon experience around, public health funding and is there concern, the specific line, is there concern that our profession increasingly appears to appeal only to a partisan minority? Not at all our experience in North Carolina. We have great legislative champions for public health in North Carolina on both sides of the aisle that really understand the health needs of their communities and all of those sorts of things. So I would say, especially at the state and local level, not our experience in North Carolina. And, I think anyone everywhere is looking at Indiana as a really great state as well, that's doing some really good across the aisle, conservative-led efforts to modernize public health. So I felt the need to speak to that one.
Okay, so before I turn it back over to Leah, maybe I'll give each speaker an opportunity to just reflect on stuff you've heard today, your own work, any, small wins or ideas you have for folks that might be working in jurisdictions where the challenges to public health authority and equity just seem incredibly insurmountable. I think, Patrick, you talked a little bit about this, right? That will help folks sort of maybe start taking some baby steps towards preserving and improving local public health authority, or even just sort of role of public health or the law, generally speaking, in this space. Maybe we start with Jeff.
Sure, darling. Thank you for the opportunity. And thank you again to everyone for, allowing me to speak on behalf of NACHO during this webinar. With respect to the question, just any small wins or anything that folks can do, at the local level. You know, I've seen small wins with respect to kind of being able to collaborate with others within communities. Local health departments that have come under threat from a variety of different sources often have been able to, at least in my experience and what I've seen, reach out to the community and identify folks who often end up being the majority of communities that are still want to see public health take action and have a role in their lives. We hear about the vocal minority a lot of times, and that is the case oftentimes when it comes to threats towards public health authority, at least coming from the local level. And so I'd encourage folks to see if they can identify champions, identify other groups, other potential partners within their communities, collaborate with them, learn how they might be able to support your efforts to make sure that you communicate the importance of public health to the full community and to those who are making decisions from a political perspective within your community. Again, thank you for giving me the opportunity to speak, and I look forward to anyone reaching out to me.
Stuff. Sarah, I'm gonna give you the last word too, and then I'll turn it over to Leah to take us out.
Well, I don't have any incredible insights to add, so we can just give it to Leah. Thank you.
All right, thanks, everybody. Leah, back to you.
Thanks, Darlene. Thank you everyone for joining us today, and a special thank you to all of our panelists. We really appreciate your contributions. I just want to remind everyone that there will be an email sent out to you all in about a week when the slides and the webinar recording are posted to the network website. You will receive those in your inbox. And additionally, you'll receive a survey link as well, a post-webinar survey, and we'd really appreciate if you could fill that out as well. So thank you all so much. I hope you have a great rest of your afternoon.